recording tonight's presentation, so please be aware of that. Also, you'll notice at the bottom of your screen there is a chat function if you would like to chat with the rest of the participants tonight, but there's also a Q&A section. So if you do have a question, please type it into the Q&A box and we will address it towards the end of the presentation. So again, type all of your questions, not necessarily in the chat, but in the Q&A. We would appreciate it greatly. All right, so again, welcome everybody to tonight's COVID-19 community update. As we mentioned, this pandemic is like nothing we've ever seen before, and it's just new. So with Arizona Science Center's mission to inspire, educate, and engage curious minds through science, we want to make sure that you're also getting the most up-to-date current science from experts and helping you to wade through some of that misinformation that might be out there. Lucky for us, this is a combination, a really committed partnership between TGen, Maricopa County Department of Public Health, and Arizona Science Center. And we have a very special guest with us tonight, Dr. David Engelthaler, who is the co-director and associate professor of the Pathogen and Microbiome Division at TGen North, the director of Public Health and Clinical Translation Center at the Pathogen and Microbiome Institute, and formerly the state epidemiologist for Arizona at the Arizona Department of Health Services. So he comes as a recommended speaker to us from Maricopa County Department of Public Health. And we're very lucky to have him because I would say that definitely qualifies him as an expert to help give us the best information. So without further ado, I'd like to turn it over tonight to Dr. Engelthaler. Thank you for being with us.
Thank you, Sarah. It's great to be here. And please let me know if the slides hang up or if there's anything with the sound as I go along. Good evening, everybody. I am thrilled to be here and be part of this ongoing partnership that we have with the Arizona Science Center and Maricopa County Department of Public Health to bring you updated information on COVID-19 and maybe give you some information that you might not be seeing elsewhere. Talk about what we're learning about this disease and as this moves along. This has really been an amazing 2 weeks since we last spoke. It's been really, the world has changed. Certainly things have changed greatly here in the United States. And we'll talk about some of the updates, what we're learning about this disease, transmission. We'll do a little bit of myth busting, talk about some rumors, and then hopefully have some time for discussion as well. I'll not rehash a lot of what I discussed 2 weeks ago. I think that video is still online and be made available. So here we'll talk a little bit more about updates and what else we're learning as we go along. See, and there's my first, there we go. Okay, so here's the update. As of today, we are now up over 660,000 cases worldwide. This is just taken from about an hour ago. And so those numbers climb by the minute, of course, but this is where we're at, 30,000 deaths worldwide. So this outbreak continues to really cover the entirety of the world. It's now on every populated country found in most counties in the US, we're seeing, and certainly here in Arizona. If we look more closely in the US, we are now the place with the most number of cases, 121,000, 122,000 cases, I believe is the latest. Total deaths about 2,000. So we're still seeing a high fatality rate, but it's not as high as what was seen in other parts of the world. Certainly not in China, and not what was and is currently being seen in many parts of Europe, especially Italy. We're averaging, depending on the population, we're averaging about 1.4, 1.5% fatality rate. That's still very, very fatal for an infectious disease, but again, not as high as 4% or even higher, what's being seen in Italy. And we'll talk about those numbers in a minute. Then if we want to look at really what's happening to date, that last map you saw was where all the cases have been documented. Here, it's showing us where all the active cases are. So there's still active cases over in the Far East, in Asian countries, certainly in China, but it's not the way it was. That map does not look like what we see in Europe and in the US. So the hotspot has absolutely shifted to the west Europe and US is where all the action is right now. A couple of other things to look at here is thinking about data. So a lot of people don't trust the data coming out of China, and that's completely reasonable. It's certainly true, though, that the number of cases in China have rapidly dropped, and the number of new cases per day and per week are nowhere where they were. So they're definitely on the downslope, but they have active disease still ongoing. The cases up there in Russia, definitely numbers I don't trust. A lot of people live in Russia. They're not reporting very many cases. We don't understand necessarily where the breakdowns are coming from, where the spread is happening, but that's probably misleading. And then when we look in kind of the equatorial regions, certainly equatorial Africa, as well as in the Americas, we're not really seeing much in the way of cases. That could have something to do with it hasn't been much transmission moved down there. Probably has a lot to do with there's not much testing available. We do know that there's cases down into South America and down into South Africa, and there's a lot of transmission going on, and they're starting to move. This is our spring, and this is their fall. It's starting to get cooler, and the concern is as it gets colder towards their winter, they're really going to see what we're seeing now. So this is, we can talk a little bit about seasonality of this virus. We're still learning what that might be. But it's a good guess that as it gets colder in the southern hemisphere, they're going to see a lot more transmission, acting like a normal respiratory virus. A little closer to home, these are the numbers as of today for Arizona. 773 cases identified with 15 deaths. So we're seeing a closer to a 2% fatality rate overall in Arizona. Again, all we're doing is looking at the most serious cases being tested, and therefore we're going to see a higher fatality rate than what is definitely the true fatality rate. That's been the same anywhere in the world. So the numbers that we'll look at a little bit later really reflect the fatality rate associated with the identified cases, which are by and large going to be the more serious cases. So this was this one is not from March 28th. This is March 18th, and this was the tracking by WHO of the number of cases depending on the region of the world by time. So that's the time on the bottom. And you can see that all that yellow, and I don't know if you can see my pointer, but all of this is China. This was the original outbreak. There's this massive peak where they caught up on cases, but you can see how that's really dropped off. And now they kind of have a steady amount of cases moving forward each week. And then here's the rest of the world. This peach color is Europe, and then this yellow color is America. Fast forward 10 days to today. Now we look at in comparison, what's happened in the US and Europe has completely dwarfed that Epi Curve, the number of cases in China. We're expanding much higher. And as I mentioned, it's the top two countries now are the US and Italy. And then a number of other countries in Europe are starting to overtake the amount of cases that were in China. So this is now what the new curve looks like, and China almost looks like a blip, but it was obviously the important blip that got this all started. I'm going to show a few kind of informational graphics from a website, informationisbeautiful.net. I think they've done a good job of grabbing data from a number of sources, data from WHO and from China and from CDC and elsewhere, to give us another look at what's happening with the disease and with recent and up-to-date data. So when we look at the types of infections, if we look at mild, which is, the flu-like, can even be walking pneumonia, where you stay at home, that would be considered mild. And that's over 80% of all the cases still. And again, we're only looking at the most serious of cases or identifying them by and large. So 80% of the cases, we see the severe cases, those are the ones that require hospitalization, about 13, 14%. And then the critical ones that really need that intensive care going into ICU units, down less than 5% of the cases that are identified. This is looking at the at-risk for fatality in both Italy and China, where we're seeing the highest fatality rates. The first brighter bars are going to be Italy in these pairs, and then the second one is China. So again, as we know, the elderly population, this is 60 to 69, 70 to 79, and then 80 plus. These are the people at most risk that are actually what are causing these fatality rates. 17% in Italy. It's been devastating for them, and it's still going on. That's the biggest problem, I think, in the world still. And even 10% in the 70 to 79-year-olds, and that drops down to 2.7% in the 60 and up. But then when you look down lower in these age numbers, and I hope you can see this is a little bit grayed out, if we're down in the 30 to 39-year-old range, that fatality rate, even in these countries with the highest fatality rate, is down at 0.1% or 1 in 1,000. So this is good news for this part of the population. Throughout the world, this is maintaining really low. It's just that Italy likely is devastated mostly for two reasons. One, they have a really inadequate state-run healthcare system that just didn't have enough resources, ventilators and ICU units to tackle the fact that they also have, the second part is a higher than average elderly population. That combination's just been devastating for them. Here's looking at those with existing conditions, and this has been talked about, not just the elderly, but those with pre-existing conditions also have a high risk for serious outcome. This again is thinking about, these are the fatality rates of people who have these different conditions. Cardiovascular disease is far and away been the most important identified as a risk. 10% of those with cardiovascular disease who get infected are fatal cases. Diabetes, 7.3%. We don't know exactly why, except for probably the immune suppressing effect of diabetes. Then there's also chronic respiratory disease, high blood pressure, cancer, also because of the immunosuppressive effect of the drugs they take. These are certainly at-risk groups. And if you don't have a condition, that fatality rate, no matter your age, is less than 1%. Here's another interesting thing that's being found is that people frequently who have high-risk conditions have multiple high-risk conditions. So again, fatality rate 1%, less than 1% for those with no conditions. Then those who have one of those conditions that we talked about, that's about a quarter of the fatalities. People with two of those conditions, that's another quarter of those fatalities. And then if you have three or more conditions, that's about 50%. So it's really narrowing in on who's the highest risk here. People who have multiple high-risk conditions, and then the elderly. Those are the ones we have to figure out how to protect and continue to protecting to keep that fatality rate low. Again, here's another one that may be a little difficult to see. I hope you can see this, which is I find very interesting, is comparing COVID-19 to pretty much all the other important viral diseases that we know about. We don't totally understand how contagious and deadly it is, but on our y-axis, this is the percent who die, so the case fatality rate. And on our x-axis down here is the number of people that get infected by another sick person, the R naught. We talked about that in the last conversation that we had, and you can go back and see that presentation. And these are different metrics that are helping us understand this disease. So when we look at comparing the COVID-19, they're saying somewhere in this box here surrounded by these orange dots is likely where we're going to be at, because it's a transmission, an R naught of 1.5 to 3.5. So that's 1.5 people to 3.5 people infected by every individual case. And then the fatality rate somewhere between 0.7 and 3.4%, given the region of the world. And obviously that changes based off of those other conditions that we just discussed. But if you look at that, what fits into that box, the Spanish flu, that is the bad flu that wiped out 50 to 100 million people back in 1918. But that's because pretty much everybody in the world got infected, and we had no way of dealing with it. That is not today's situation. We don't see everybody getting infected, at least not during this current part of the pandemic. And we do have ways to deal with these seriously infected people. And also the Spanish flu had a tremendous impact on the young and the healthy. And that's because really what killed people in the Spanish flu the 1918 flu was our own immune system, our own immune response to the virus took over. So those with the healthiest immune system were the ones to have the most serious disease and who died the fastest. Here, that's not the case with COVID-19. So they're while similar on this chart, they're very distinct. And then you look at the extremes, the highest fatality rates. The bird flu or avian flu, also known as H5N1, has a fatality rate of close to 60%. But we do not see very much transmission actually occurring with avian flu. There's a very few number of cases of humans who get it, and they don't transmit it readily to other humans, which is why we don't see a global outbreak of that. Ebola is high up here, higher transmission rate, about 50% on average fatality rate. MERS up here as well, and we've talked about MERS, the Middle Eastern Respiratory Syndrome, also one of these coronaviruses that escaped out of animals and got into humans. Just about 35% fatality rate, but again, not very transmissible between people. So that's why it's on this side of the graph. You look over here, measles and chickenpox, these are the viruses that, the human viruses that spread the fastest. You get 8, 9, 10, 12 people infected for every individual case. Thank goodness we have really good vaccines for these now. We have to stay on top of those to help keep these people out of our healthcare system as COVID-19 continues to really roll across the countryside and cause real problems in some areas. Another way to compare is to look at incubation periods, and this is one that we're still really starting to learn. For the COVID-19, this is kind of the typical time frame that we're looking at, 2 to 7 days, but we think that it could be less than that, even down to 1 day, all the way going out to there's reported cases up to 11 and 12 days before disease starts after you get exposed. That's your incubation period. And it may go out even further than that. But the vast majority of cases are in this range, 2 to 7 days. And that's very common for viral diseases. And if we compare that to the swine flu, the pandemic flu from 2009, it's almost exactly the same. So it acts a lot like flu that way. A couple of days post-exposure, up to a week is when you would likely start to develop disease. And that could be anything from asymptomatic disease up to the very serious disease. And we'll talk about asymptomatic disease here in a minute. We can look at other things like norovirus. This usually happens in 24 to 48 hours. This is the vomiting disease. This is what used to devastate cruise ships before COVID-19. And then chickenpox actually can be out there. You're usually a couple of weeks post-exposure before you develop symptoms. And then the worst, Ebola, this could be anywhere from a day all the way out to 3 weeks before people actually start to develop disease. So it covers a very long period of time. And then 2 more graphs from this website. I really love this website, so you guys can check these out too. And they update them pretty regularly. This one's only a couple days old in comparing locations. So we're looking here, USA, the most number of cases is obviously out of date by a few days because we're up to 122,000. And Italy has now surpassed China, but it still gives us a feel looking at the number of cases and comparing countries on this bar graph, but then looking at the number of deaths. So we look here with the US having relatively few or limited deaths compared to what's actually happening in Italy. So we can actually look at this case fatality rate here. So the US 1.4%, and that's been holding steady ever since that really started in the US. China 4%, that's been holding steady as well. And then Italy at 10+%, again, devastating. Spain 7.4%, Iran at 7%. These are 7.6%. These are the countries that are having the hardest time dealing with it. France has a very high fatality rate as well. The UK has been suffering pretty bad, as well as the Netherlands. These are all up over 5%. But by and large, the rest of the world is getting down in the 1, 2, and 3% range. We look at the total cases per million. So this is a rate within the country and how it's really affected a country. So Switzerland, not a lot of people in Switzerland, but their cases, when you look at the overall population, they have the highest or had the highest at 2 days ago at that number is 1,300 per million. So it just gives us an idea of how much of the country has been really hit by the virus. So Switzerland and Italy and Spain all up there. When we look at the US, we're still down here. So this number is likely to continue to grow. We don't know how far as cases per million, but the Chinese cases, 56 per million. There's so many people in China. Those probably aren't totally accurate, but it does show you that not everybody is being infected at the same time. And then you look at the deaths per million. Again, Italy by far the worst place in the world for deaths. And Spain is getting pretty close behind that. And then if we look at the US, we're down here at 4 deaths per million within the country. So, and we know those numbers are going to continue to grow, but yeah, we're all thinking about Italy these days. And then the last one of these slides is looking at the trajectory. So this is looking at the total number of confirmed cases here on the y-axis, and then looking at the rate or the time of the outbreak in that country. So it's really looking at, this is actually the number of days since the 100th case was identified. And that's a number that epidemiologists look at to say, okay, now there's enough people that you can actually start to see community transmission. And now it's not just new disease coming in from other countries. So when we see that, these trajectories, places like Singapore and Japan, they're essentially looking at a trajectory much lower than much of the rest of the country as far as, or the world, as far as how many new cases get added per day. Essentially, they're seeing a doubling of every 10 days, and that's what this dotted line in the background says. When we look at the US, which is here in red, it's looking more like this particular line, which is doubling every 2 days. So that's not good. For an outbreak. That's really the way China started. It was on that steep slope as well, and then that curve started to bend a little bit until it flattened out. And we talked about flattening out the curve and how we do that with social distancing and quarantine. That seems to what's been happening in China. Italy, maybe that curve is beginning to bend a little bit now, doubling every 3 days. They certainly were on this doubling every 2 days. Same with Iran. South Korea is flattened out, so that curve looks more like what China is, where it's not doubling at all anymore. A couple of things that I wanted to bring up that have been discussed in the news and some new data that's coming out. The Washington long-term care facility. So in the US, we have the same risk populations, but one of the phenomena that we've seen, and this has been true in Italy as well, is these long-term care facilities where we house elderly together and how something devastating can happen, like COVID-19. In this particular case, that first index patient in this care facility in King County, which is Seattle, occurred on February 28th. Within that same facility, by March 18th, there was 167 residents, staff, and visitors found infected. That's 101 residents, 50 staff, 16 visitors. So it was not just the residents, the elderly there, but the people caring for them that were infected. But it's the elderly that were dying. 38% of all the elderly cases in that facility have died, which is obviously incredibly devastating. We look at the staff, 0% fatality rate. These are the younger, healthier, the nurses, the other care staff. That fatality rate is low, but they were certainly part of the spread within that facility. In fact, it is the epidemiology on this has identified 8 other long-term care facilities that became directly infected from this one, either by transfer of patients or staff that work at multiple facilities carrying the virus there. And in those facilities, again, seeing these kind of devastating effects. Now, public health has jumped on this and helped move out patients into different settings and trying to reduce the overall death rate, and that's significantly dropped off for the elderly in these types of facilities. But there are 30 facilities throughout the Seattle area, King County area, that do have cases. So that is something that we're watching and looking at throughout the country now. Certainly in Arizona, we know public health has been paying very close attention to these facilities and doing testing and screening and making sure that we're not having the same situation that occurred in Washington. This is just an Epi Curve to show really what happened in that particular facility and how it didn't all happen at the beginning. We could just see that those first couple of cases identified infections started occurring and then spread quickly throughout the facility. Another thing that's been in the news a lot, chloroquine. Chloroquine and hydroxychloroquine have been used for treating malaria and lupus and rheumatoid arthritis. These are anti-malarial drugs that we've had for a very long time and effective. There seem to have been some initial studies to show that there was a positive effect in the use of chloroquine under a medical setting, but there's been no controlled studies to date that have been performed to really prove that this is going to be a useful tool across the board for healthcare workers to do. There are studies now ongoing. We're going to learn more about this, but unfortunately some news came out about this and people started scrambling to use it for treatment, self-administering, and we absolutely cannot have self-administering. People get sick from the inappropriate use of it, and actually finding other chloroquine products, including fish aquarium cleaner. That's a veterinary labeled product. It helps actually keep the bacteria and fungus down in fish tanks. And unfortunately here in Arizona, people have used this. One person has died, another person very sick, intensive care, from using this to try to self-administer. Absolutely cannot do this because those are not appropriately labeled. We don't know what kind of dosing is appropriate, and they're not for human use. So we're learning more about this, and we know that people want drugs quickly, and there are dozens and dozens of studies around the world right now on repurposing drugs like this, as well as looking at some possible new antiviral agents or antiviral approaches. So hang in there. The biomedical world's definitely working on this. There's also been discussion about asymptomatic cases, and we think that this is really important. We think that there's plenty of evidence. Lots of studies are showing asymptomatic cases and subclinical cases are very common. That means a lot more people are infected out there than we really know, and good, because they are typically not getting very sick, and therefore not plugging up the healthcare system. We do think that this is probably more prevalent where we do see active cases. You probably have a lot more asymptomatic cases around there. You probably don't, if there's not much activity, actual cases happening in an area, there's probably not much asymptomatic cases either. But healthcare workers are absolutely at risk. We know healthcare workers can pick up this virus while treating patients. We don't know how many may actually be picking up and be asymptomatic, and how often are they actually potentially spreading the disease, either to themselves or to other patients. And then that also gets to this idea of pre-symptomatic spread. There's a recent study that just came out this week that suggests that pre-symptomatic spread may be common, where people are spreading it before they actually get symptoms, and they get symptoms and then they get sick, but you wouldn't even know that you're spreading it. And it's kind of like asymptomatic, but before, people that go on to develop symptoms. I've gone through this study. The authors use an average of a 5.2 day incubation period, and then they looked at matched pairs where they know one person spread it to another, and then they saw transmission occurring about 5.7 days between contacts within that. And so they came up with a number of 2.5 days before symptom onset that people can spread it. Well, I think that that's the statistical possibility here, but I don't think it brings reality into play in a number of ways. One, you're using an average incubation period. The incubation period could be much shorter in some of these cases, which means that people get infected earlier and then have a incubation period that allows them to develop the virus before symptoms. That pre-symptomatic spread, or that it also occurs later, so that pre-symptomatic spread could be somewhere outside those boundaries. And it likely is going to be occurring just before symptoms. This is when we know that the most virus seems to be occurring in the upper respiratory system tract, is just before symptoms, and as symptoms are occurring, that's probably when people are most infectious. So there's a lot of viruses that occur where people can be infectious just up to 24 hours prior to the disease actually showing up. That's because they have so much virus being shed in the respiratory tract. This is something we're going to watch closely. Certainly affects the epidemiology and the public health response to try to find contacts. It's not just when you are symptomatic, but maybe a day or two beforehand. We still have a lot to learn in this area. And then the rumor mill. I mentioned the rumor mill that's out there. Some of these we addressed last time, and some that are ongoing. So one that's recently popped up is that ibuprofen makes COVID-19 worse. People want to use ibuprofen if they get a fever, and one set of doctors in France actually came out and suggested that ibuprofen may make this worse. Nobody else has seen this. No one else has documented this. And in fact, the WHO is still saying ibuprofen and acetaminophen are appropriate to use for fever reducers, excuse me, for COVID-19. So this is, we would not say that this is myth has been busted, but the data do not support this, and there's no reason not to use ibuprofen at this time. There's been a number of reports about how this can be spread in a lot of different ways. And including by ectoparasites or arthropods, so fleas, ticks, mosquitoes that will bite one person and then bite another. It seems maybe to make sense that if a tick or a mosquito bit somebody that was infected, they go bite somebody else. There's absolutely no evidence of this with this or any other coronavirus. This is fake news, just being spread by people who are trying to be interesting. Spread by touching contaminated objects. So somebody coughs or sneezes on a surface. Potentially, if they're highly infected, they can contaminate that surface, and the virus can spread or survive on that surface for a while. So we do think that this can be spread by touching these contaminated objects. We don't know how important it is in the overall epidemiology of the disease. We think that the vast majority of all cases are still spread by the aerosolization of micro droplets that are contaminated with virus. So that happens when people cough and sneeze, and that's when most transmission is going to occur, is when people are symptomatic that way. COVID-19 can be spread by packages from China. Now, everybody is ordering everything online. No one's going to stores, or there's limited travel to stores to buy stuff. And lo and behold, everything we buy comes out of China. There really is no evidence that this has occurred at any time. Packages get shipped through all sorts of conditions, heat, exposed to air in different areas, likely gets dried out. If there was anything that was contaminated, that we're not seeing that there's ever been a case of spread by this way. So we'll put that in the not likely category. That the virus came out of a secret lab in China or the US. I think I addressed this last time. This is still circulating out there. Absolutely, positively, this is fake news. We know where this virus came from. This virus came out of bats in China, likely out of horseshoe bats. We don't know that for sure yet. And then moved between potentially one or two more animals, maybe in these Chinese markets. That's certainly how SARS occurred. That's how a number of viruses come out of China, these live markets where they have all sorts of animals mixed together. And so we know that this virus all came from a single source. The genomics tell us that, and it wasn't out of a secret government lab. And then the use of bleach, alcohol, UV lamps for disinfecting the skin. This is something we don't want people to do. Bleach is terrible for the skin. Isopropyl alcohol, straight alcohol, bad for the skin, and UV lamps can cause damage as well. Hand sanitizers and soap. Soap with water, these are the things to use still. Okay, now I want to try to do something. I'm not sure if this is going to work, but we're going to try. I want to show you some of the cool new tools that we're using to help track this virus here in Arizona. And if you'll hang in there, this is going to be my last attempted set of slides. Oh, sorry, I want to do a new share here, switch over, and hopefully this works. And Sari will tell me if it's not. This is a tool that was actually used in Seattle to understand how the virus spread there, and the fact that it had been spreading for a long time before they identified their first community transmission. What we're seeing in Arizona is that's not the case. Our first case was a case from at a university that was out of China. And then it was several weeks later before the next cases were identified. we were able to show that they did not come from that first case. They've come from a number of different areas. And so what we see over on this side of this tool is a what we call a phylogenetic tree, a phylogeny. It's also it's essentially a family tree, how strains are related to each other. And then when we tie that to geography, we can understand where strains are. So we're doing sequencing of all the positive strains in Arizona, and this sequencing gives us all this genomic information. We fit it into this family tree. This is showing all genomes found and sequenced around the world, and the ones that are heavy lines here are leading out to the Arizona cases that are these dots. This is the first batch. We got new samples going in daily, but we can see here's a strain this is a second strain that we found that came straight out of China. We can see that it's most similar to Hubei province. If you guys can see that, sorry, things keep flashing on and off. Whereas these particular strains are all seen to be coming out of Washington. Now, the Washington strains definitely came out of China, so there's similarity with China. They all have a common ancestor here, but the Washington strains definitely came into Arizona and started spreading around. This strain came out of England here. These strains up here seem to have come out of France as well. And then this last one came out of Washington. That strain likely originated out of this French group, and the French group originated out of China. This particular strain here looks out of Scotland or some part of the UK, and then this one came out of Switzerland. So we can actually trace down where strains are coming from as they are showing up in Arizona. It's not just the same strains circulating around. We have a number of strains that have come from different areas that are causing outbreaks. And this is going to give us a lot of information over the next couple of weeks about what's happening with the current state. We can actually play this, and maybe you guys can see this in real time, and you can see the lines moving on the map a little bit. We can see what just showed up there in Washington. And then as we get closer to understanding where the strains have been recently moving, we'll see them popping up. Sorry, this is moving really slow. Okay, so these are some of the strains that are showing up, and we can see starting to pop up on the tree, and then all of a sudden we'll start to see them showing up in the US. So you can see more strains coming out of Europe there on that line. It's really faint, but also showing up in Washington. And then lastly, I think the Arizona cases will show up they all showed up at one time. I had that moving too quickly. But this is a tool that's available. It's nextstrain.org, and we can actually, everybody can go and look at the strains from around the world, and we're going to continue to add Arizona strains into this. We're sharing this with the epidemiologists. We have a great coalition of researchers in Arizona, from U of A to NAU to TGen, all working together to do this analysis and try to really understand the genomics of this organism. We're sharing this data for biomedical researchers as well, to develop new drugs and new vaccines, hopefully. And we actually have researchers at TGen who are looking at this data to do just that. So that's one of the cool things we're working on. I mentioned that, TGen has a clinical diagnostic lab. We're doing screening and thinking about healthcare worker screening, trying to help set that up in different parts of the state so we can better protect our healthcare workers. And with that, I want to jump back to my last slide and see if this will work. And there. So it's a little shout out for TGen and the genomic first responders here at TGen, they're literally working 7-day a week, 80 plus hours a week, have been for a month, supporting the public health system, working with Maricopa County Department of Public Health and the state health department, tribal health departments, and healthcare systems across the state. We're doing all of this because of donations, philanthropic gifts, foundations, and the like. We're providing this testing at this point for most of these kind of some disadvantaged communities and smaller rural communities for free because of this. So if you're so inclined, we certainly appreciate that support. Continue to support Arizona Science Center as well as your county health officers. And Sari, I'll turn it over to you.
Thank you, Dr. Engelthaler. That was really a great and informational update. So I appreciate you in particular going through your rumor mill there. That helps a lot. So at this point in the conversation, we will flip over to doing taking questions and going through the Q&A. And we do have several here. And
Okay.
I'm just going to start at the top and go down. So we have a question. Are blood clots considered in the cardiovascular disease group?
If people have blood clots, that's a great question. I'll have to admit, I don't know that answer. That's something that we'll have to look up. I'm imagining that it's not been one of those that's been highly characterized in COVID-19 cases. So there's probably not a ton of data around that, but I'll do my best to get that information. And Sari, I think on this, I'm not sure if we can on this board answer some of these questions. I'd be happy to go back and type some of those in and make those available as well.
Great, thank you. We'll document those.
Great.
All right, so our next question. I heard that the virus was becoming more dangerous to younger populations as it has moved west. Is there any truth to that?
I don't think that we think it's becoming more dangerous to younger populations. We have younger populations, so more are getting infected. And we're going to learn more about the epidemiology. There's an older population in a lot of parts of the world that were affected early, and that's where we got much of our information. So the virus itself is not changing in a way that we know that it's causing a different effect on people. We just are now getting different segments of the population more infected, and those numbers are going to go up. And let me say one other thing too. So for the younger populations, there's also been more studies come out to suggest that the young are not immune to this disease. There's no doubt about that. It's just they have a much lower percentage of having symptomatic cases. There have been a few serious cases in teenagers and younger. There's been one known infant death in the world that I could find, and that was in a infant that had serious pre-existing condition, bowel blockage and other multi-organ failure. And so COVID-19 just devastated. But even kids with other pre-existing conditions or other at-risk situations, we're not seeing any fatalities, which is great news, but kids can still get sick.
Which is actually a good segue into our next question with an attendee who has questions about understanding children in daycare centers and the spread there. And it's a multi-part question, also looking at children who may have ongoing allergy problems, which you did sort of address the other fatalities we've seen with pre-existing conditions, but how will pediatricians be able to distinguish between ongoing allergy, asthmatic issues, and COVID-19 type issues?
Yeah, so obviously the patient history and what they have is an important part of the overall understanding of the effect. This does not look like allergies. Even people with mild disease, just the runny nose or just the sneezing, does not seem to be really an important symptom, even for these mild cases. It's usually the mild cases, you get a mild fever, something maybe hovering around 100 or a little bit more, and then a cough. The allergy symptoms do not get confused. You could have allergy symptoms, but it's typically with those other symptoms, so it won't look just like allergies. We do see in very young kids the symptoms being a fever and a runny nose, and that might cause some confusion, but the fever is still usually a telltale sign there.
I'm going to jump around a little here if anybody's looking at the list of questions, but can you discuss herd immunity a little bit? There's been some talk of if we can become immune to this, or if we will see that resurgence like with the flu where you can get it over and over. And then, which ties into another question of how the genetics are changing with this virus. It seems like they're changing very quickly, so will it have an effect on the ability to make a vaccine?
Yeah, those are great questions, and obviously the Arizona Science Center audience is really smart, informed people, which is great. So these are great questions. Thinking about herd immunity. So herd immunity is this concept that you get a large segment of the population infected or immune I should say immune from being infected or from vaccines. And then that allows for us to prevent the spread of the disease. And for some diseases, you need to have a really high herd immunity, background immunity, in order to prevent an outbreak from continuing. And that would be like measles, because it's so infectious. We don't know what that's really going to be for COVID-19. We do think that we're starting to see herd immunity occur in some of these places like South Korea and like China, where they're not getting a lot of new cases. So probably the higher risk, or the people that were getting exposed, they're generating some type of immunity that's probably lasting, and it's slowing down the ability for this virus to find new hosts to infect. So we think that's going to be an important part of the epidemiology. It's a reason why there's a lot of people working on vaccines right now. And it's also a reason why the next go around of this, if we have another one, so if this starts to drop off like it has in other places, especially during the summer, we'll get it come back, but we may still see a fair bit of immunity. There's been some studies recently to show that non-human primates that have been infected cannot be reinfected after they recovered from the disease, at least not for a month. And that's just how long the study went. This may be many months that we get some type of support, maybe years. We don't know that yet. So it's something that we're going to watch closely. Now, of course, I answered that multi-part question, the first part, very lengthy, and so now I forgot the second part of the question, Sari.
No, not a problem. That was great. The second part of the question is about, with all the changes happening as far as what we're learning about the genetics of the virus, will that have an effect on the ability to make a vaccine?
Yeah, so this virus, like all viruses, mutates. And the flu virus mutates in multiple ways. And so we have to have new vaccines come out every year to try to adjust to the flu virus. And because it changes in ways that coronavirus doesn't, we may not need to always have new vaccines if and when we get those vaccines. The flu virus can actually change large chunks of its genome with other flu viruses. You get this Frankenstein virus effect happening, and then you need a whole new vaccine. Or it just accumulates a lot of changes over multiple years, and then you need to change the vaccine a little bit. With coronavirus, we are seeing mutations, and these mutations are allowing us to track the differences and where the strains are, but they're not that many mutations. The virus, a virus like this can only handle so many mutations in genes before it starts to just disrupt the ability of the virus to do its job, which is to infect cells and disrupt those cells. So we don't know that we're going to see a lot of changes to the fact that immunity won't be lasting. The thought is that based off what we know about this and some of the early serology work, we may have lasting immunity, at least for a while, and maybe it does change year by year, and hopefully we can monitor it the same way we do flu and adjust those vaccines once they become available.
Thank you. Now, back towards the beginning of your presentation, you talked a little bit about the seasonality of what we might see happening in on some other continents, but will we anticipate a slowdown of this virus as we move into the warmer summer months? So basically, will the heat help slow down the virus?
Well, I think that's the current general thinking. It's what I believe will likely happen based off of what we know about respiratory viruses in general. I don't think it's going to disappear. We see that there are cases in warm parts of the world right now. We think that as those places start to cool down, such as in South Africa, parts of South America, they're going to be devastated by this. And that's partially because they also have a whole new population in these places that we haven't really looked at yet, which is the severely immune suppressed. We have really incredible HIV populations, HIV and TB populations, tuberculosis. We don't know how COVID-19 is going to respond to that, if it's going to really take over and devastate. And we think that the cooler months are going to allow for that spread to happen much greater than what they're seeing. But we do know that in these warm parts of the world, we're seeing it in equatorial parts of the world, the virus can hang out, it can move, but I think it's part of the effect that we see with social distancing. It's going to be less ability for this virus to move. People aren't huddled indoors during the cold, in those parts of the world. That's why I think there's slower viral spread. We don't know enough yet because there's not enough testing in those parts of the world, but I do think we'll start to see a slowdown as it really starts to warm up at some point.
Thank you. And forgive me if you already answered this, but it's not coming to my mind. There is a specific question about how long it might take to make a vaccine for this virus.
Well, the good news is there's dozens, literally dozens of biomedical groups working on dozens of vaccine candidates. And so that's great. It means that we're taking a lot of swings at this thing. There are already a couple that are in the early phase 1 and even phase 2 trials. And those are the trials to make sure that the vaccines are safe. And then they have to be put in on very controlled trials to make sure that the vaccines are actually then effective. That takes months. We can't learn enough very early on. We can move quickly to develop vaccines, but now we got to test them out. And so it's going to be months of testing these vaccines. And then once something is identified as safe and effective, then it's got to move into vaccine production. That's a very costly and resource consuming process to develop vaccines for millions and hundreds of millions of people. That's all going to happen. We got the resources, we have the technology to do that, but we don't have necessarily the time to prevent cases for the next many months with vaccines.
So, and forgive me, we're just going to keep going down the list here.
Sure.
There are two questions about the survival time of the virus outside of the human body. So if you could address that. One question asked about the virus on steel versus plastic versus fabric. And you did touch on this in the rumor mill with groceries, packages, mail, et cetera. And sort of tagged on to that, not using bleach, alcohol, or UV lamps on skin, but is that something that we should be using on objects?
Yeah, so a couple things here. There have been some very controlled studies to look at the virus and spreading it like you would a cough, and then seeing if it lands on a surface, a table, a doorknob, something like that, and how long it lasts. And those studies have shown that it can last for several hours and maybe even multiple days under this very controlled circumstance. In real life, we don't know. We just think every environment is a little bit different, so it's going to be hard to say how long that could last, but it certainly could be hours. And that means that we have to do those things like the decontamination of surfaces and the constantly washing of our hands. If we touch a surface that's infected with a live virus, that doesn't necessarily mean we're going to get infected. We wash our hands before we stick our fingers in our mouth or rub our eyes or rub our nose. That'll help prevent any spread from that type of a transmission route. We don't know, how long this, as our season continues to change, that will also change how long things can last on the surfaces. If it's hotter and drier, we know that viruses dry up. If it's cooler and moister, viruses can survive a much longer period of time. So that's, again, gets back to the seasonality of this, but we can combat this by continually to wash our hands and decontaminate surfaces.
Thank you. Okay, we've got some great questions. When the acute phase of this outbreak is over, given that there's been only spotty testing in Arizona, how are we going to figure out how many people were infected here in Arizona? And then would we be able to then assess current versus prior infection if we've got multiple infections at this time?
Yeah, those are great questions. So one way for us to know how many people were infected after kind of this outbreak starts to subside a little bit, and actually even while it's going on, is the use of serology tests. These are the blood tests that we use for a lot of other things that can tell us if somebody has antibody, if they've developed antibody. We think it's going to be very useful because not only will it tell us who's infected, it may also give us an understanding of who may be immune, at least for some period of time. What is that overall herd immunity when we look at large community screening? So at TGen, with our partners at NAU, we're working on developing that capability within our labs to do serologic analysis. There are other tests already available. We don't really know exactly how good they are at detecting acute cases versus past exposure yet. That's things we still have to learn by using these tests, but we are able to start to look now for antibody in these particular, in different populations. This is, and one of the things that we can do is there are different types of antibodies that your body produces during the infection versus after the infection. You develop what's called IgM antibody, and there's tests that can look specifically for IgM antibody during the first multiple days and maybe even weeks of infection. And then that starts to subside and you develop an IgG antibody, and that's what we look for long-term antibody. And that's the antibody that we think gives protective effect for a certain period of time, which we don't know how that long that is. Hopefully it's months and maybe it's years.
Thank you. All right, our last questions here, I'm kind of tying them together as well. We have, of course, been all trying to promote our safe social distancing. We're doing that here tonight by doing a virtual event. Arizona isn't yet in a shelter-in-place situation, and there's been some misinformation in the news about whether or not that's effective. Could you give your professional opinion on the effectiveness and if that could help with flattening the curve?
Yeah, there's no doubt that it does help with flattening the curve. There's thinking about different uses of these types of technologies. If you don't mind, I'm going to see if I can show you one more slide, or it's a visualization that helps us to understand. Let me see if I can do this real quick.
And while you're bringing that up too, I'll sort of add to that one of the questions asked if Arizona will turn into a situation like New York, and maybe what happened there and what the difference is for our situation here.
Yeah. Okay. So let me get to that in a second. Let me see if this will work. So this is a nice thing done by the Washington Post, and it is done on statistical models about how fast a virus moves under different circumstances. If you're in a population where people move around and interact with each other, but you're not using any social distancing, this kind of helps give us, and this might be slowed down a little bit because of the internet, but we could see as infected dots, those orange dots bump into an uninfected dot, they will change. And so we can see that curve increasing. And Sari, tell me if this isn't being visualized. I don't know if you guys can see this.
It is.
Okay,
it's a little slow, but it's working.
Okay, and as that curve increases at the top, that's the total number of cases, and it really peaks out. You get really everybody starting to be infected, and then you start to see some being immune. They all start turning purple, and then everybody's infected, and it hits the healthcare system really hard. It's not showing you how many people are actually dying from this, but in this type of a situation, a lot more people die because you just hit the healthcare system all at once. Now let's move down to a situation where like in China, where they use kind of an absolute lockdown, you get a lot of people infected that are locked down in a certain situation, such as certain communities were really locked down. But as they start to open those up, those people will start to go out, and without using social distancing measures, they're going to go out and infect everybody else pretty quickly. Again, it's moving a little slow because of the internet here. This is not necessarily real time, but again, you get this very large affected Epi Curve, a large number of people, everybody gets infected this way. And if you go to a situation, one more that I want to show here is where you use social distancing, like what is being put in play. You have people not interact with each other, and this is because you have fewer opportunities for that virus to bang around. Now, it certainly does, but it does much more slowly, and you can see the curve at the top there, the number of new cases happening over a given period of time. That curve is really flattened out. So statistically,
I'm going to interrupt really quickly because I have a feeling maybe we're not seeing actually the correct image that you wanted. We're still seeing the epidemiology slide, and I thought maybe that would be on the transmission side of that, but I don't think we're seeing the same thing that you're describing.
You're not. I am so sorry. Anyway, I guess I apologize because this was a kind of an on the fly. I was trying to show something. The point being is that it has been studied under different circumstances where you don't use anything, everybody eventually gets infected, and you just take over the healthcare system. If you use social distancing, it does flatten out that curve. It slows the ability of the virus to move from person to person. It's just physically it does that, and therefore we're still going to get the same number of cases, but it pushes it out over a longer period of time, and the healthcare system can absorb it much better. And the healthcare system is so far to date doing that in Maricopa County and in other places. In some places it's really bad. Italy had a really tough time at this, and they were not able to socially distance their people. So yeah, so just to kind of, I guess, wrap that up, we definitely do see a a difference when we're using these types of measures to put in place. And then the New York situation, you have a different epidemiological model. You have millions of people living on top of millions of people. We don't have that in Arizona. Typically, we're a large, Phoenix is a very large suburban community, lots of rural areas throughout Arizona. People don't live the same way that they do in a place like New York, where there's so much more opportunity for the virus to spread, people to bump into each other in apartment complex, elevators and the like. So it's they've had a real tough time at it too.
Thank you. And with that, I want to be conscious of everybody's time. We are just past our 7:30 mark for the evening. And it looks like we've gone through the majority of the questions and covered all the information tonight. So Dr. Engelthaler, thank you so much for all the information and helping us wade through all of the vast amounts of information that are out there and helping to clarify for us.
You bet, Sari.
We appreciate it. Well, and thank you to all of you who joined us tonight. We really do appreciate it. We hope this answered a lot of the questions that you may have on the current situation surrounding COVID-19 here in our community in Arizona. If you're looking for more information or additional resources, of course, please check out the Translational Genomics website at tgen.org, see what they're working on. And also check out, of course, all the resources we have at azscience.org, continuing your science education at home and resources on current news, etc. So thank you again for joining us tonight. We can't wait to see you next time. Stay safe, everybody.